Yeah, so good afternoon, everyone, and welcome to today's session. I'm Dr. Ratna. I represent an organization called Patient Academy for Innovation and Research, and this is an organization that works with patients and patient groups, as well as community members and family members, to increase their capacities to manage their conditions better through awareness generation programs like the ones that we are having today, building capacities through online as well as offline workshops, as well as self-paced courses and several other activities around varied topics. One of the areas that we work in is women's health, and we do a lot of work around raising awareness amongst women as well as family members around topics that have stigma or are challenging for women to manage on their own. And through these efforts, we try to bring more awareness within the communities as well as the population at large, so that treatments and diagnostics are made available to women who need them as early as possible, and that the stigma and discrimination that is sometimes associated with these conditions is minimized. So today's session will be around uh, we work on endometriosis as well as PCOS, and both these conditions are associated with infertility. So today's discussion will be around awareness around PCOS and infertility and how to manage fertility issues. I will start the session by introducing the panelists, and we will then move on to the main session. So if we can have the next slide, please. So this is myself. As I said, I run an organization called Patient Academy for Innovation and Research. I also do a lot of other work around patient advocacy as representative in many other organizations like the ISPOR Patient Council. ISPOR is the International Society for Pharmaceutical Outcome Research, and this works on health economics and outcomes research and how we can bring the value of healthcare to patients for the services that they are trying to receive, and how can we make it better in terms of better accessibility and giving a better price point. I also represent an organization called the International Alliance of Patient Organization as its International Alliance of Patient Organization as its immediate past chair. And as you can see, I've got a lot of experience. So we can move further to the next slide. It's my pleasure and honor to introduce our panelist today, Dr. Seema Pandey. She is the Chief Consultant Reproductive Medicine, Infertility and IVF, and a gynecologist and obstetrician at Seema Hospital and Eva Fertility Clinic and IVF Center. Her primary areas of interest remain as a reproductive medicine specialist with a special focus on PCOS infertility and assisted reproductive technologies. She's also an endoscopic surgeon and has a diploma in ultrasound. She has the aim of producing the maximum evidence-based management protocols and research that suit Indian patients, and believes in the feral origin of adult diseases, and that's why loves spreading awareness amongst future mothers through her camps in girls' schools and rural areas. She's a nature lover and loves to express herself through poetry and prose. And Dr. Seema, I also love to write poetry, so we must catch up sometime.
Sure.
And our next panelist who will be joining us today is Ms. Priya Suved, and she is a PCOS warrior and a patient advocate. She loves teaching art and has her own YouTube channel. This is something that I have to learn from you, Priya. And the channel is called Priya Sharing Life, where she's been sharing her inspiring PCOS journey with the audience around India as well as globally, and managing PCOS symptoms, conceiving with PCOS, and her life after a baby, her 9-month journey of pregnancy, etc. She's a positive soul who believes that this disease doesn't define her, and everyone should be aware of PCOS as a condition, and that no one should live with myths and misconceptions. So welcome, Priyal, and
Thank you
it's
so
really an
much.
honor to have you today. And just as a brief background before I call Dr. Seema to present her views around the myths and misconceptions around PCOS and infertility. The World Health Organization over the past 2 years has been holding consultations with people with lived experience. And when they call people with lived experience, it is people who actually have the condition, whether it is diabetes, cancer, many other long-term chronic conditions, COPD, etc. And these consultations have tried to elicit what patients really want and whether what they want is being met by the healthcare providers, whether it's the pharmaceutical industry or the physicians or allied healthcare professionals. And quite a lot of startling information has emerged from these discussions. The final report will be published somewhere later this year. But we did not have any representation from people with women's health conditions. So we didn't have any endometriosis patient with lived experience or PCOS patient with lived experience. And usually these conditions are left behind because they are not very much in the focus and are not considered lifelong diseases under quote unquote non-communicable disease or NCD category. So I think we should try and include the lived experience of the patient voice that comes from these groups as well when there are further consultations, so that their experience can also enhance and enrich the data and the information that WHO is collecting. So again, not to take too much time, I would like to now call on Dr. Seema to make her presentation, which I'm sure will be very, very inspiring and educative as well. So over to you, Dr. Seema.
At the outset, thank you so much, Ratna, and I'm honored and obliged to be on this platform. Am I audible? Because, yeah, I am.
Yes, you are audible.
Yes. And this is a sheer pleasure to share this platform with all of you. As said, I am a person who believes in fetal origin of adult diseases, and unfortunately, polycystic ovarian syndrome is one of those diseases. And my whole aim, my life revolves around advocating, making awareness in those who cannot reach to us directly. And that's why I'm living in a village. Basically, I practice in a village in Eastern UP you have not even heard of. That place is called Atrolia in Azamgarh. So, yeah.
Oh, okay.
Yes. So, because I believe that 80% of the diseases we are facing today are result of our faulty lifestyle choices we have made throughout the journey called life. And that's the reason I felt really, really happy when Khushbu approached me. Thank you, Khushbu. Thank you, Ratna. So as I was telling you, it is the most common heterogeneous female disorder of reproductive age group, that is starting from 18 to 40 years. It is related to hormones, so we call it endocrinopathy, anything to do with so. And as I told you, it doesn't only involve your hormones. In fact, it involves your metabolic process too, and these two together make polycystic ovarian syndrome, which is polygenic, means there are multiple causes which cause polycystic ovarian syndrome: polyfactorial, systemic, inflammatory, autoimmune disease with dysregulated steroid state. Basically, it is a lifestyle disease. All you have to understand is that. And any lifestyle disease like diabetes, hypertension, heart disease, all are lifestyle diseases, and they are not curable as of now. But the good thing is that you can take care of this disease and take the control in your own hands. And I always call that diabetes and polycystic ovarian syndrome, they are like twin siblings. They share the same kind of genetic pattern. If your mother is having it, you will be having it, or you can have it. If your sister is having, chances are you will get it more clearly. These patients, they have infertility as one of the leading symptoms in our country. Most of the time when patient starts caring about her menstrual cycle, irregular menses not leading to pregnancy, they report to us. That is the commonest time, but times are changing now. People are becoming more aware. People like Dr. Ratna, they are spreading a lot of awareness, and girls, they come to me in this village and they tell me, ma'am, I have PCOS and please tell me what to do. So as I was already telling you that polycystic ovarian syndrome patients are every one girl in five among five. So is prevalence and incidence in our country is from 6% to 36%, which is reported, and that is just a tip of iceberg. If I divide it like broadly, 80% of these females, they are obese or overweight. 20% could be of normal weight or lean PCOS. 50 to 70% have a lot of hair here, wherever you don't desire hair, male pattern of hair growth, because this disease is as a result of insulin resistance in your body and production of lot of male hormones in your body. So a time, if time was there, I would have explained you very simply how does it occur, but because of time constraint, I will not go to pathophysiology. But these two things together, suppose somebody requires 1 gram of insulin to digest their food, your body requires 10 gram, 20 gram, and this extra insulin along with male hormones just disturbs all the reproductive function. Reproductive function means whatever is related to your uterus, ovaries, pituitary, hypothalamic, ovarian axis, and that leads to all the disturbances. So treatment, and every obese person is not PCOS and every PCOS is not obese. You will have to understand, as I was telling you, family history is very important. If you don't have sister, your mother didn't have, if you have your father and brother and they are diabetic or hypertensive, that is also an association. And this 24/7 lifestyle which we are leading, and our food, our working condition is becoming refined and refined, we are leading towards sedentary life. So pe baith ke everything is on our fingertip. In this COVID lockdown, we have learned to order food also. Most of the time, Swiggy, Zomato is there. So our food and our working habits are being very refined. At the same time, we are not working and we are eating a lot of refined things. And let me tell you here that this polycystic ovarian syndrome was a mutational change to just protect our females in the time of hunter-gatherers. When we were hunter-gatherers, at that time, men used to go for hunting, and women, they used to take care of elderly and children, and they used to die of hunger and famine, and they use or childbirth. So to prevent that, this insulin resistance was introduced to our body by nature to protect our females. And look at the paradox. Now we have plenty of food, but still this disease is increasing day by day. So that is a very important point which we have to take into consideration. And all the factors, all the things which we are eating, our environmental factors, our stress. In India, the girl is starting from womb, she is under stress. Her mom is just praying that she should be having child most of the time. I am not saying everyone. And as I told you that 18 to 40 years and adolescent PCOS 15 to 30 years is the age where we get this. So to diagnose polycystic ovarian syndrome, a Japanese lady can also have PCOS, your Indian can also have, and African can also have. So to make a uniform diagnosis, all these over this, they came to an agreement of following Rotterdam diagnostic criteria, which requires two features: either you are not ovulating and you are having menstrual irregulation, along with either clinical and or biochemical signs of hyperandrogenism, that is hirsutism, acne, and alopecia, means loss of hair, and your polycystic ovaries. And out of these three features, we got 4 types of male. We call it phenotypes. What is the meaning of phenotype? Whenever we are having whatever visual expression of a disease we are having, that is called phenotype, and genetic expression is called genotype. So there are 4 kinds of polycystic ovarian syndrome patient. A and B are typical obese patients having a lot of hair, acne, thick skin with other things. and they are not ovulating. And second group B, everything is there, but their ovaries are normal. Third group is they are having ovulatory cycle, but they are also having a lot of hormonal disturbances. They could be either obese or thin. So this decides what kind of treatment. Knowing what phenotype you are will decide that what kind of treatment and in what doses the medicines you require whenever we are going to do our fertility treatment. So before labeling anyone as polycystic ovarian syndrome, we rule out other diseases like thyroid and hyperprolactinemia. Hyperprolactin is a hormone which is required for milk ejection. And this hormone, what does it do? Whenever a female is breastfeeding, there is natural contraception because of this prolactin hormone. And thyroid condition and prolactin condition, both the presentation of both these conditions looks like a polycystic ovarian syndrome. Similarly, sometimes there is a cap-like gland on top of your kidneys that is called adrenal gland, and that becomes dysfunctional. That time also the presentation is similar like polycystic ovarian syndrome. And sometimes somebody is going to they are not having enough hormones, either production wise or they are having a lot of hormone, then also the same picture is produced. So whenever you are going to a doctor for your fertility treatment, they would like to make the diagnosis. After that, they will try to do the specific test that would be your serum anti-Mullerian hormone and ultrasound, and plus they will rule out if you are overweight. BMI we use very frequently to talk. In Indian females, anything beyond 23 is overweight till 27, 28, and then you become obese. While in international literature, anyone whose BMI is 25 or more, that person is called overweight. So whenever an overweight, obese, let's divide them into two groups, obese PCOS and normal or lean PCOS. So whenever an obese PCOS come to me, before starting her fertility treatment, I would like to rule out any kind of diabetes, pre-diabetes, or deranged glucose test by doing 75% glucose tolerance test. We call it OGTT or HbA1c. And I would like to see their cholesterol because they are deranged most of the time in these patients. And if they are normal, then only we would like to proceed with other investigations which are related to their fertility need. As I told you, anti-Mullerian hormone, it is produced by the cells inside your ovaries, which are very small, less than 3 mm, and they tell you your reproductive potential. And in polycystic ovarian syndrome patients, they are subfertile not because they don't have eggs. They have a lot of eggs. Their AMH secretion is dysregulated, so their AMH is very high. Higher the AMH, difficult is the pregnancy fertility treatment for a doctor. So she would like to know what your AMH is. Apart from this, she would also like to do a transvaginal scan, and through which I would like to see how many antral follicles, or those cysts you call follicles, we call it, are there, and accordingly I would like to plan your treatment. So these are few tests. If you are having a lot of hair, lot of other things, or you are losing hair or a lot of acne, I might require to do a testosterone level, that is a male hormone, and that is raised in polycystic ovarian syndrome patients, phenotype A, B, C. D, if we see, it is towards higher side of the normal, but it is always higher than the normal population, a friend who is not having polycystic ovarian syndrome. So phenotype decides if you are A and B. I would be having very difficult time. I'll have to streamline your lifestyle, your diet, your exercise, your vitamin intake, your I will ask for so many things to do before I prescribe any kind of medication whenever I am going to treat your fertility. While phenotype C and D, they are lean or normal weight, here the problem will not be of ovulation. You would be ovulating or you would respond to normal treatment, normal medication, but there are chances that you can produce so many eggs that could lead to a condition called ovarian hyperstimulation syndrome, and that is not good. That is a man-made or iatrogenic complication which can put your life into danger. Apart from that, if many eggs are fertilized, you might be having multi-fetal gestation like twins, triplets, quadruplets, pentaplets. So we have to be really careful. So your doctor would like to know what condition you are in, what are your hormone levels, how do you look, how does your ovary look, and what is your anti-Mullerian hormone level. So A and B, difficult to get pregnant. C and D are very nice. D has the highest chances of getting pregnant. So what happens? Why polycystic ovarian syndrome patients, they do not conceive? And to explain that, I would just like to tell you something. This is uterus, this is ovary, these are two fallopian tubes. Every time when you start menstruating, first 4 days, one egg is selected, that we call as recruitment. That happens either from right or left ovary. That particular egg is not there, that cyst, that follicle we call it, that follicle which is selected, recruited, we call it Graafian follicle. Egg is lying inside that particular follicle, and that follicle starts growing from day 5 to till 13 or 14. When it becomes 20 to 25 it ruptures and egg releases, and that is called ovulation. And then that egg is taken by this tube, and if husband wife they live together, sperm goes like this. There is one hole or tube is connected to uterus, and sperm and egg, they meet in this fallopian tube, and a start of pregnancy takes place in tube. So what happens in polycystic ovarian syndrome patient? Instead of one follicle getting selected, many follicles they get selected to grow up, or they become recruited. And human has the limited reproductive potential. You hardly see twins or triplets happening to humans without medication, once in thousands and lakh. So our body is meant to nurture one egg, and here multiple eggs are coming together to get recruited. So food is being divided among so many, so none of them get nourished, none of them get start developing or growing. So all of them, they remain small, and they are visible on ultrasound as a string of pearl when we are doing their ultrasound. And your severity of the disease will depend on how many eggs are being recruited. If there are 3-4, they'll grow slow, and then while the time they rupture, your uterine cavity, which has endometrial lining, it will get tired, it will not make pregnancy. Or sometimes there is no ovulation, and just shedding off will occur 3 months, 4 months, 5 months later. So what happens? Because of this, I told you there are two conditions. One, you are insulin resistant, so a lot of insulin is being released along with your male hormones, which is being taken care by or guided by a hormone released from your pituitary, that is called LH, luteinizing hormone. These two, they get very high in PCOD, and they just make this oocyte quality very, very bad, and that gives rise to, and as the severity of disease increases, the level of LH and insulin goes higher and higher, and worse quality of oocytes we get. So if you compare yourself with your friend who is not having PCOS, you will also get pregnant. Just remember one thing, you are going to get pregnant, but it will be 10 times difficult for you to get pregnant in comparison to your friend who is not having polycystic ovarian syndrome. So whenever we are giving them medication, this is written for ART. If I am just trying to make you ovulate by medications, sometimes you will not ovulate at all. Or if I increase the dose, you will start producing so many eggs that it will give the chances of getting multiple fetal gestation, and that is twin, triplet, quadruplet, and that is not good too. So PCOS patient, whenever we are treating, they are tough to stimulate, they have lot of follicles inside, so their egg is one egg doesn't grow properly, and once they rupture, fertilization takes place, these patients, they have higher chances of having miscarriage. The reason being this obesity. As I told you, 80% of patients, they are obese. So apart from PCOS per se, this obesity, hyperinsulinemia, and hyper LH, all these three can create miscarriage independently by either disturbing the quality of your eggs or disturbing the receptivity of this endometrial lining. So PCOS patients are difficult to get pregnant. Once they become pregnant, they have higher chances of getting miscarriages than a normal person. So how do I treat them? Lifestyle. That is the most important thing which we have to take care of. I call it pre-pregnancy optimization. Suppose you are having polycystic ovarian syndrome, whatever weight you are having, if you are an obese PCOS, even if you lose 5 to 10% of your weight, your chances of getting regular ovulation, because what is the defect? You are not ovulating, that's why you are not becoming pregnant. And that ovulation will start happening if you lose 5 to 10% of your basic weight. Suppose you are 70, you become 65 or 60 kgs, your chances of getting ovulation and pregnancy naturally will increase a lot. Second thing, if you are lean, very thin, you have to maintain a normal body weight. Your BMI should be somewhere between 18 to 23. You have to eat lots of, and one thing you have to remember, even if you are lean or thin PCOS or normal weight PCOS, this insulin resistance is there in more than 70% of cases. So the diet which you are eating, that should take care of. Insulin is mainly required. Whatever we are eating, your macros has to be metabolized immediately, and the kind of energy they require to give you to make your body go around. Similarly, the same thing, increasing in size inside that follicle, it requires lot of energy. There are 1,000 extra mitochondria to just bring this egg to that stage where it can produce a beautiful life. So for that, you require to have proper insulin function, and that is in your hands. I always tell my patient there are two defects. Your body is having a lot of male hormones and your insulin secretion is high because your body is not responding to the command of insulin. This insulin command you can take care of by doing what? By taking care of your diet. Suppose if you stop eating lot of carbohydrates like bread, whatever, pasta, pizza, burger, all this junk food, and anything which is white, soft, and tastes very good, goes very smoothly inside, that creates, these are the food, like sugar is taken as a standard glycemic index, we call it. So we compare everything to that sugar. तो food which is having low glycemic index, अगर आप वो खाते हैं तो आपका sugar का level अचानक से पीक नहीं करेगा, शुगर के साथ का तो वो होगा. दूसरी कंडीशन where insulin can be taken control of and बॉडी को इंसुलिन की बात करनी पड़ती है, दैट इज एक्सरसाइज. एन इमरजेंसी सिचुएशन your body will respond to insulin. Not eating a lot of carbohydrate, you will not create the requirement of lot of insulin by your body. So that is called pre-pregnancy optimization. Your vitamin D level is seen to be low, so we always give vitamin D. I don't get the test done for that. I just start giving because the ultraviolet rays which we are getting, it has some deficiency, so that our skin is not making enough vitamin D in spite of living in a country where sun is around 11 months a year. And second thing, folic acid is very important. I would like to ask you to have that. I'll ask you to quit smoking, drinking, any kind of drug, any kind of habit which is not good for your baby. I would like you and your partner to stop, and that is called pre-pregnancy optimization. Particularly, I will talk in detail about diet and exercise, especially in polycystic ovarian syndrome patients. So whenever we are talking about that, three things. First, what are you eating? How are you exercising? And third, your mindset, behavioral therapy. You have to be conditioned in a way that whatever I am telling, you understand it. My principle is, if I am able to make that understanding, and you once you understand that this is good, this is bad for you, you will always follow that. So diet, as per I was talking about the guideline, as per our international guideline, any diet which is healthy and balanced is good. If you want to lose weight, you have to decrease the calories. So we call it hypocaloric diet. Every female, most of the females are sedentary. Sedentary means housewives, teachers, clerks, doctors, entrepreneurs, all these people except for laborers, we are leading a sedentary lifestyle. So our daily requirement of calorie is 1200 to 1500. So if you want to decrease your weight, you have to decrease your calorie by 500 to 750 calorie a day. But the constitution of your food should not be unbalanced, like imbalance. Like you cannot just cut down carb completely, you cannot just cut down protein completely, you have to take everything but in moderation. So hypocaloric diet is the most favorite diet as per the guidelines and evidence. But it has always been shown that low carbohydrate diet, especially in fertility related issues, does very good. And here is, I was telling you, complex carbs and simple carbs. Simple carbs, I told you, all the junk foods and sweet, all of sweetness, cold drinks, all these come in this category. And whole grain, all these quinoa and whatever, jowar, bajra, ragi, millets, what these things, or fruits, green leafy vegetables, all these, they are having complex carbohydrates. So whenever you are planning to get pregnant, all you have to do is you cut down on your macro carbohydrate portion, and that will lead to improved pregnancy chances, ovulation chances, your menstrual irregularity will be corrected. At the same time, your miscarriage rate will be decreased. And it has been seen, the longer you practice it, better are the effects. So, and second is anti-inflammatory diet. Polycystic ovarian syndrome is said to create lot of inflammation, especially in obese PCOS. And the solution is in your kitchen. This all these dietary things which I'm showing you, your cinnamon, your fenugreek, your cumin, everything is there. If you just start flaxseed, all these things, if you start incorporating in your diet, you will start improving your fertility potential. All these people who who are showing any kind of cholesterol disturbance, hypertension, they should go for this kind of diet. Fenugreek, your berries and flaxseed are very good insulin sensitizers. They decrease the insulin resistance of your body. And if you incorporate these the kind of things in your diet, that will improve your fertility outcome. Mediterranean diet, which is being practiced across the Mediterranean Sea, which has lot of omega-3 fatty acids in form of seafood and lot of other things. You can see green leafy vegetables is supposed to be the ideal diet anyone should follow. For making it simple, you just have to do mindful eating. Your breakfast should be somewhere around 8 to 9, and your last meal should never exceed 8 p.m., preferably 7 p.m. And breakfast should be the heaviest and dinner should be the lightest. So these things I talked about, people who were obese. What happens if you are thin PCOS? At that time, as I told you, you have to maintain your weight. You have to take that anti-inflammatory diet. I have told you, lot of proteins, and take care of good exercise. Exercise not only improves your looks, your fitness, it also will improve your pregnancy outcome. Exercise directly doesn't affect your fertility. By decreasing your obesity, it will decrease your insulin resistance, your LH, so you will get regular ovulation. Once you start ovulating regularly, your chances of pregnancy will be better. If you are not able to exercise daily, 10,000 step count is the best way to do your exercise count. Nowadays, everybody is having smartphone or watches. Otherwise, try to, if you cannot go to a gym, try to lift your buckets, 2-liter bottles in your hand, and try to do at least 3 days strength exercises to increase your muscle mass. That will take care of your insulin part, apart from decreasing your weight. And this weight which is decreased, you are fit. Once you become pregnant, the chances of getting hypertension, diabetes, miscarriages, C-section, all will decrease. So, and if you are not aiming at pregnancy, otherwise also it will decrease the chances of all the lifestyle related diseases. So for my these patients who are polycystic ovarian syndrome, I always tell them that exercise for you is as important as brushing the teeth for others. So that was. Now coming to the treatment part, which a doctors give. Once your lifestyle modification has taken place, you have done everything, either 20% people, they will get pregnant. Rest who are not getting pregnant, if they are obese, we start them on some medication. The popular medications, drug of choice as an ovulation induction agent for us is letrozole. If letrozole doesn't work in 3 cycles, there are various permutations and combination we use for letrozole to make you ovulate and get pregnant. Initially, we used to use Clomid or clomiphene citrate, which was proven that though it makes you ovulate, but it doesn't give you pregnancy as much as it should be giving, because it adversely affects the endometrial lining of the uterus. So letrozole gives better pregnancy rate, better live birth rate, means take home baby rate. If that is not working, then you are called CC or letrozole resistant, and there is the role of metformin, which is a insulin sensitizer, and we add it to your diet, to your medication, and chances of you getting pregnant is better. If that doesn't work, then we give you a hormonal injections called gonadotropins, and we can do IUI or only time intercourse, we can tell you by monitoring. But if that also fails, then in vitro fertilization or IVF comes as a third line of treatment. The surgical treatment, laparoscopic ovarian drilling, is not good for obese patients, so I have not included here. So in lean patients, as I told you, if they do not respond to oral ovulagens, they are young, the married life time duration is not very much, their LH is very high, we can just drill their ovaries at 4-5 places, release some hormone, and in next 6 months they can get pregnant. But this is not a preferred mode of treatment because it has lot of complications in terms of anesthetic complications, post-op, pre-op complications, and sometimes your ovarian reserve decreases. So it's always better, if you are not responding to oral treatment, you should be going for gonadotropin. If gonadotropin injections are, because injections are painful and you have to take it for longer time, that's why people avoid it. So until unless affordability is an issue, we always recommend gonadotropins as second line, and if it is not working, the IVF as third line is the quickest way of you getting pregnant. Because, and there are multiple advantages, let me tell you, this will take care of how many eggs, as many eggs as you are producing. We'll make the embryos, we'll freeze it, and we'll start putting 1 or 2 embryos in your womb. So chances of getting multiple fetal gestation will drastically decrease, getting ovarian hyperstimulation will drastically decrease, and all those complications related to pregnancy will decrease tremendously. And that is the way how do we go about it. So when we are doing in vitro fertilization, first we just take you, we give you injections, and we start making, we make embryos and keep it, then we make you menstruate, then we start creating this endometrial lining, and once it is created nicely, not created, it has grown nicely, we do embryo transfer. Let me tell you about Iui Intrauterine Insemination. That is nothing. In polycystic ovarian syndrome patient, there is no scope for IUI. Why? These patients, the basic problem is hormone. Either they are not ovulating, or even after ovulation, because of that hormonal disturbance, they are not getting pregnant. So IUI is only done when you want to buy time, when you are very young and everything is looking perfectly fine and you are not getting pregnant. So we take your husband's semen, we wash it, and we just put it inside your uterine cavity. From here, this has to go by its own to the tube and do the fertilization. So chances of getting pregnancy with only IOI in PCOS patient is very, very low. While getting pregnant with in vitro fertilization or IVF is as high as 50 to 55% as per your age, duration, and other things. Your AMH and your ultrasound will always tell me what kind of doses I have to give, how much medication you require to take, and metformin is a kind of boon. Whenever nothing is working, we start you on metformin, though it causes GI upset, B complex deficiency, sometimes lactic acidosis, but all metabolic features of PCOS, if they are not being treated alone by hormones, or you're not getting pregnant alone with medications, we always like to add metformin to take care of that insulin resistance, which is stopping you to make pregnant. Fine. So 3 drugs I have told you. Letrozole is the preferred one. Clomiphene citrate we are not using anymore. Metformin alone we don't use. And clomiphene resistance and failure used to happen earlier, and those patients, they used to require injectables. Letrozole is superior. I told you surgery should not be done. Gonadotropins, only difficulty is you have to take everyday injection. They are expensive. If not monitored properly, or your cycle being cancelled properly, you can land up in OHSs or multifetal gestation. So gonadotropin cannot be given by each and every doctor. You have to meet a fertility specialist who knows about it. And this is IUI. This is the way we do IVF. Once this lady gets pregnant, what happens to her? The chances of miscarriage, I have already told you, are more. Then chances of getting gestational diabetes by the age of 30, more than 50% of polycystic ovarian syndrome patients, they become diabetic, because we are not taking care of our lifestyle that we can prevent. And same thing happens if we do not take care of our pre-pregnancy optimization, weight, diet, exercise, and we make it our way of living, we may end up in gestational diabetes, pregnancy-induced hypertension, pre-eclamptic toxemia, premature rupture of membrane, and preterm labor, leading to a small baby. And small for gestational age means small baby. And suppose if you started leaking at 6 months, that pregnancy is a wastage. Even at 7 months, if you started leaking, that baby will go to NICU, will be suffering a lot, will be given a lot of medications, there'll be side effects. So it's always better that first of all, in my clinic, until unless you lose 3 to 5 kgs, you are obese, I do not prescribe any kind of fertility medication, because I want you to enjoy the process of pregnancy, that journey to be remembered, and I want you to enjoy your baby. So chances of getting C-section will increase. If you are very obese, that will also, that may you may end up into stitch rupture or infection, inflammation, your baby will go to an ICU. So all these complications are there. So whenever if you are polycystic ovarian syndrome, having polycystic ovarian syndrome, it's not like that your life is ended here, you are a bichara person. No, you can take control of your life, everything is in your control. You're just menstruating infrequently, rest everything is fine in your body. You just have to be mindful about what are you eating, how are you walking, how much exercise are you doing, and how are you making choices about your family, your fertility, and other things. Here boys are just proving they want to. I already know that our coffee, please do it in time so that later on you don't regret your choices. And otherwise, you will be having your baby. Your reproductive span is 2 years longer than any other normal lady, but you have to work harder to achieve this stage. Thank you so much. I hope whatever I told you guys made some sense, and I'm open to any question because I wasn't knowing what all I have to tell. So I tried to just make it concise.
Thank you, Dr. Seema. That was really very, very insightful and quite nicely put in the sense it was not too complicated, didn't have too much of medical jargon, was easy to understand, and brought in a lot of insights on what people need to do to be able to manage their condition, which is much beyond just the medical management of it. So there's a lot that the person who has PCOS can do on their own in terms of managing their diet, managing their lifestyle, etc. So, and a lot of times what happens is that people are very dependent on just the medication and forget that there are other things that they are supposed to be doing to be able to get a hold of their life once again. So thanks a lot. There are a few questions that we would like you to address, but
Yes,
before
yes,
we do
definitely.
that, I thought it would be a good idea to hear Priya's journey so that, the patients can and the viewers can connect with her journey and listen to her. So, Priya, if you can come on and share your journey with us, that will be wonderful.
Yeah, hi. So myself Priyal, and I would like to go in Hindi because most of the viewers are like from India only, and it will be more
Yes,
helpful for them to understand. As I have my YouTube channel, and mostly people prefer that कि Hindi में बोलो, so I would love to go with Hindi. So
most
basically,
certainly. Please.
yeah, मैं मध्य प्रदेश से हूँ और मेरे husband की वजह से I'm living in Bangalore since he's working there. आफ्टर मैरिज मुझे 2017 में डायग्नोज हुआ था PCOS. लाइक आई वाज गेटिंग लॉट ऑफ पिंपल्स, बहुत ज़्यादा चेहरे पे पिंपल्स हो रहे थे, एंड मुझे डर्मेटोलॉजिस्ट के पास जाना पड़ा उसकी वजह से. एंड उनने जब मेरा फेस देखा, साथ में मुझे काफ़ी ज़्यादा हेयर भी थे चिन पर एंड साइड लॉक्स पर. फिर उनने मुझसे कहा कि आप कुछ अपने टेस्ट करवा लो, वो ज्यादा अच्छा होगा। जब मैंने टेस्ट कराए सारे अपने, तो उसमें मुझे पता चला कि मुझे पॉलिसिस्टिक ओवरियन सिंड्रोम है। और उस समय मुझे नहीं लगता कि बहुत सारे लोगों को इस बारे में नॉलेज था, क्योंकि मुझे तो बिल्कुल भी नहीं था। और आप बिलीव नहीं करोगे, मैं इतना ज्यादा डर गई थी जब मुझे पता चला कि लाइक मुझे ये हो गई है प्रॉब्लम। और जैसे कि सीमा मैम ने कहा कि हम गूगल में पढ़ते हैं बहुत ज्यादा, जब मैंने गूगल में देखा ये सब चीजें, तो उसमें बहुत ज्यादा अजीब, बहुत काफी कुछ वियर्ड इस तरीके की चीजें लिखी थी, एंड कि समझ नहीं आ रहा था क्या करूं। देन हम डॉक्टर के पास गए, डॉक्टर ने मेटफॉर्मिन प्रिस्क्राइब की, बट आई वाज नॉट रेडी टू टेक दैट मेटफॉर्मिन, बिल्कुल मैं तैयार नहीं थी। उनने जो जो डॉक्टर ने कहा वो सारी चीजें मैंने की। फिर यूट्यूब पे सर्च किया, उसमें से काफी सारी डाइट्स देखी, ट्राई करी, बट कुछ भी लाइक वर्क नहीं हो रहा था वहां पर फिर धीरे धीरे एक्सरसाइज और डाइट से मैंने ये पेड डाइट्स ली, क्योंकि आप जैसे सीमा मैम ने कहा कि आप कुछ भी ऐसे रैंडमली नहीं कर सकते हो कि कार्ब आपने बंद कर दिया, सिर्फ आप प्रोटीन लेने लगे। उस तरीके से थोड़ा बहुत तो पीसीओएस काफी हद तक एक दबा रहा, बट उसके बाद जब बात आई कंसीव करने की, तब काफी सारे इश्यू आए, कंसीव नहीं हो रहा था। फिर फाइनली मैंने बैंगलोर में डॉक्टर को दिखाया, एंड तब मुझे पता चला कि मेरे प्रोलैक्टिन्स बहुत ज्यादा बढ़े हुए थे। वो एक रीजन था कि मैं कंसीव नहीं कर पा रही थी। देन सिंपली डॉक्टर ने लाइक प्रोलैक्टिन की मेडिसिन दी, एंड जैसे सीमा मैम ने कहा कि आपको डाइट पे बहुत फोकस करना है और आपको एक्सरसाइज पे करना है, तो डॉक्टर ने उस वक्त भी मुझे यही कहा था कि लाइक यू हैव टू गो अराउंड 10,000 स्टेप्स डेली, आप करो, वेट लॉस करो, एंड देन आप इजीली कंसीव कर लोगे। सो वंस आई लॉस्ट अराउंड 6 kgs, उसके बाद मैंने कंसीव कर लिया था। और अगर मैं सोसाइटी की बात करूँ, तो अगर आप जब बहुत ज्यादा मोटे होते जाते हो, तो सोसाइटी आपको बहुत ज्यादा लाइक प्रेशराइज करती। बहुत ज्यादा टॉन्ट सुनने मिल चुके हैं मुझे, चेहरे पे, बॉडी पे। मुझे एग्जैक्टली पता नहीं आपने मेरा यूट्यूब चैनल देखा है कि नहीं देखा है। वहां पर मेरा यही कहना है कि आप जैसे हो आप वैसे रहो, बस आपको अपनी लाइफस्टाइल पे वर्कआउट करते रहना है। आप दूसरों को मत सुनो कि वो क्या बोल रहा है, बस आप अपना देखते जाओ कि आप कैसे अपने आप को ठीक रखते हो।
Thank you. Thank you, Priya.
Excellent, Priyal.
थैंक यू सो मच,
That's
वेलकम।
excellent. And people like you really motivate a lot of other people. And we haven't spoken about the mental health issues that come with obesity and infertility. And a lot of people do suffer silently because they have no one to share with. So when we hear stories of positivity like yours, it inspires a lot of people to actually move forward and manage their condition better. So thank you for joining us today.
श्योर मैम।
We do have a few questions. The first question is actually a case, and what I would do is to recommend that she gets in touch with you directly, Dr. Pandey, because it won't be good to answer publicly. It's basically a young girl who has been trying to receive treatment that works for her, but has not been successful, and she
I
has
lost your
amenorrhea.
voice.
Yeah, so it's about a young girl who is suffering from amenorrhea for 5 years, has tried some treatments, but they have not worked for her. So I would recommend that she gets in touch with a specialist, maybe yourself later. There
Yeah.
is one question. Yeah, there's one question which says that the person has a lot of chronic issues, one being PCOS, which is the least of her problems. However, she has a beard and stomach hair, and her husband finds it very unattractive, which is a problem. So, what is a good solution for hirsutism or extra hair?
Yeah. So thank you, Ratna. Actually, I wasn't able to focus on, I couldn't read it completely. So first thing, one thing, as Priyal was telling, basically it is a public forum and we don't know how much you will absorb at once. That's why I try to cut. And nowadays I am doing mental health issues and PCOS as a separate lecture for doctors to sensitize them, because even as a physician we are not that much sensitive. We very clearly, very openly, rudely we tell them, until unless you lose weight you are not going to get anything. So let me tell you, losing weight in a polycystic ovarian syndrome is not that easy as you think. She might be doing every possible thing, but it doesn't go that easily. You have to go an extra mile, and sometimes you have to take help, a professional help, to shed it off. So please, if there is someone who's overweight or having a lot of hair or hirsutism, please don't make fun of that person, because PCOS per se makes you more prone to get anxiety and depression. And apart from that, these issues, your body shaming, your hormonal issues leading to weight and all these things, fertility medications, infertility, all these things together land these patients into anxiety and depression. So be very sensitive to them, be very positive. I just request, if you cannot say something positive, just be neutral. Please leave them alone. That is one request I want to do. Second thing, as regarding prolactin, as I've told you in the beginning, that polycystic ovarian syndrome is a completely clinical diagnosis by ruling out other disorders, and thyroid and prolactin are two conditions. And apart from that, thyroid and prolactin are disturbed in PCOS per se as well. So that's why we get it tested. If required, we get medication. Coming to this excess hair part. So you will have to do two things. Immediate effect will not come with the medication. For that, you just have to go for shaving, waxing, or any kind of local treatment which you can easily afford, including lasers. And there are some creams, but those creams are very expensive, and such a large area, where will you put? And that might give some dark spot and something. So first of all, you will, आपको कोई भी local therapy use करनी पड़ेगी. जैसे हमारे हाथों पे बाल आ जाते हैं तो हम वैक्सिंग कराते हैं, तो you can get it done for here as well. और वो उससे दोबारा आपको, लड़कियों को ये लगता है कि उनको दाढ़ी निकलने लग जाएगी अगर वो ऐसा करेंगे. ऐसा बिल्कुल नहीं होता है. And waxing is a very safe option, and the epilators and all people use. Along with that, वो hair और ना आए, उसके लिए आपको जो है, पहले आपका एक ट्रीटमेंट चलता है. एक हेयर को बाहर निकलने में 9 महीने का टाइम लगता है स्किन से बाहर आने में. तो आपकी उस हेयर के ट्रीटमेंट के लिए मिनिमम 9 महीने आपको दवा खानी पड़ेगी. वो कॉन्ट्रासेप्टिव पिल्स ही होते हैं जो हम खिलाते हैं. अगर उससे वो कंट्रोल हो जाता है तो बेस्ट होता है. 90% लोग का उसी से कंट्रोल हो जाता है. उससे अगर वो नहीं कंट्रोल होता है तो उसमें और तरह के एंटी एंड्रोजन, क्योंकि ये मेल हार्मोन बढ़ने से हो रहा है, तो हम और तरह की दवाएं उसमें जोड़ते हैं. लेकिन सबसे सेफेस्ट एंड अच्छा है, उसकी पिल्स आती हैं, जैसे क्रिम्सन 35, डैन 35, बहुत सारे डॉक्टर्स ने आप लोग को प्रिस्क्राइब किए होंगे, आपको याद होगा. तो वो पिल्स आप 6 से 9 महीने खाइए अगर आपको सूट कर रहा है, और फिर वो एक बार हार्मोन लेवल नॉर्मल हो जाएगा तो आपके बॉडी में वो हेयर बनना बंद हो जाएगा. और दूसरी चीज, इसके साथ उस हेयर पे भी लाइफस्टाइल का फर्क पड़ेगा. डाइट, एक्सरसाइज उसके साथ करते रहना पड़ेगा. पूरी तरह से सिर्फ आपको दवाओं पे डिपेंडेंट नहीं रह सकते हैं. एंड यू विल गेट वंडरफुल ट्रेमेंडस रिस्पॉन्स टू दैट.
Thank you. There is one person who has asked about whether thin people can get PCOS as well. I think that was already answered as part of your
I told
presentation.
about the management separately for thin people.
Yes, exactly. So one person has asked, I have a question, can I have PCOS if my pelvic exam was normal? I think this has also been answered, because the screening for
Pelvic
PCOS
examination
is...
doesn't have to do anything with your PCOS.
Yeah, exactly. So diagnostics for PCOS is much wider and broader than just a pelvic examination. And therefore, really, a pelvic examination will really not rule out PCOS.
And Ratna, here I would like to add 3 things. Who can be having PCOS? अगर आपके पीरियड्स इरेगुलर हैं, इरेगुलर का मतलब है ऊपर जाके आ रहे हैं डेट से, 2 महीने, 3 महीने, 4 महीने, 5 महीने नहीं आ रहे हैं, या सिर्फ दवा खा के आ रहे हैं, उसके साथ आपको बहुत सारे बाल निकल रहे हैं, या यहाँ से बाल गिर रहे हैं, जिन जगहों पे बाल चाहिए वहां से खत्म हो रहे हैं और बाकी जगहों पे आ रहे हैं। आपका वेट अचानक बढ़ रहा है जिसपे आप कुछ भी कर रहे हैं काम नहीं कर रहा है, आपको ढेर सारे पिंपल्स आ गए हैं। अगर ऐसा लगातार कई महीने हो रहा है तो आपको पीसीओ हो सकता है और आपको डॉक्टर से मिलना चाहिए, अपने आप को सेल्फ डायग्नोज नहीं करना चाहिए।
Thank you. And you talked about inflammation. So I have one question. A lot of conditions require anti-inflammatory diet, and usually most autoimmune conditions
Yes.
are advised anti-inflammatory diet. So has PCOS any relationship to any autoimmune condition?
Not exactly, but let me tell you, even autoimmunity is related to our lifestyle. I said
Yes.
no, 80% of diseases we are facing today, those are the consequences of faulty choices. Western, I had lot to speak, but I didn't have time to talk about everything. Our Western
True.
style of diet, what we are doing, we have
Hmm.
like our diet used to be the perfect diet. If I talk about my North Indian diet, every day in the lunch we take dal, chapati, chawal, sabji, salad, dahi. That is a perfect balance of micro and macro. Similarly, you go south, you go west, but we have
Yeah.
forgotten that diet. We are trying to bring that quinoa from US and having as a superfood, and we are forgetting our local superfood, which your
True.
geographic, your body, your soil is deficient in particular thing, and to just make it proper, your soil gives that kind of fruit, that kind of food, and you are not eating that. You are going, and we have become a global citizen, we have become a 24/7 kind of citizen. तो हमारी तो
जल्दी
कोई
जी
वो
बोलेंगे।
मेलेटोनिन जो यहाँ से निकलता है रात में, यहाँ एक ग्लैंड है वो मेलेटोनिन देती है, वो मेलेटोनिन आपकी बायोलॉजिकल क्लॉक के अलावा आपकी ओवरीज पे भी काम करती है। उसको काम करने का के लिए अंधेरा चाहिए, उसको ब्लू लाइट नहीं चाहिए, और हम तो अपना व्हाट्सएप, यूट्यूब, एवरीथिंग वी आर ओपनिंग व्हेन वी वांट टू रिलैक्स, तो हम तो उसको टाइम ही नहीं दे रहे। तो दिस इन्फ्लेमेशन बेसिकली हैपेंस बिकॉज ऑफ ओबेसिटी, एंड ओबेसिटी नहीं है तो आपकी बॉडी में
Yeah.
और भी सारी चीजें हैं। या प्रियल वांटेड टू से समथिंग।
या एक्चुअली जो आप बोल रहे हो वो बहुत सही बोल रहे हो। मैं बस यहाँ पर एक छोटी सी अपनी बात रखना चाहती हूँ क्योंकि काफी सारे व्यूअर्स हैं। आप बिल्कुल घबराओ मत अगर आप कंसीव नहीं कर पा रहे हो, क्योंकि मैं बहुत ज्यादा घबरा गई थी। बस जो मैडम बोल रही है डॉक्टर सीमा मैम, आप वो करो और अपनी डाइट और एक्सरसाइज पे फोकस करो और एक अच्छे डॉक्टर से मिलो, और उसी डॉक्टर से मिलना जो आपको चिल्लाए नहीं, क्योंकि मैंने ये सब फेस किया है, जो अच्छे से आपको गाइड कर सके, वो बहुत मैटर करता है। सो यही
Very
है वो
true.
बात। या
Yeah, very true. Priyal, a sympathetic doctor will work wonders. So more than the medicines, I think an attitude to listen
या
and to be
दैट्स ट्रू।
empathetic,
या
yeah,
दैट्स ट्रू।
works wonders. So yeah, thank you so much. There is one question to which I don't know what kind of answer can be given. So it
Yeah.
says, why does female with PCOS shed a lot more blood than someone who does not have PCOS? As per my understanding, it was the other way around. I think they have
Other way
amenorrhea,
around,
not,
peace,
yeah,
yeah.
it's, yeah,
95% of PCOS, they either don't bleed or they bleed scanty.
correct.
5%,
Okay.
less than 5%, their periods are irregular in terms of they get polymenorrhagia, or in between when you did not bleed for 6 months, 7 months, 9 months, 12 months, a phase comes when hormonal imbalance, your body is producing lot of estrogen, and that keeps that endometrial lining. I was telling you, the only job nature or God has given this lining is to keep a baby, to nourish that
Yeah,
baby, and for that it gets prepared every month. It sheds off in the menses, and then again it starts producing itself on its own. So if there is unopposed action of estrogen for long, your lining becomes very thick, and then by sheer mechanical pressure it starts shedding off. There
yeah.
is no hormonal control, so it doesn't stop on its own, and you keep bleeding, and that is less than 5%. And that is the reason why these people, they have increased chances of getting endometrial cancer later on in life. Not very much, but little increased
Small
percent.
percent. Thank you, ma'am. So the last question is, are there alternative therapies to add on to the modern methods? So does Ayurveda or other methods also offer any therapies in this, and are they useful?
So, Dr. Ratna, our Ayurveda is very rich. The only thing is we don't go properly about it.
Yeah, yeah.
Whosoever I know any Ayurvedic doctor, I come from IMS BHU, Banaras Hindu University, which has got a biggest Ayurveda
Correct.
department. So I have never heard any PCOS treatment or making us aware of that kind of thing. And majority of Ayurveda people, they are practicing allopathy or mixed pathy. So we
Correct.
are not producing evidences, but the same kind of evidence when comes from West, as I was telling you about curcumin, cumin, this fenugreek, all these things, that deshi ghee, which we were avoiding like a plague. We were not
Yes.
having. It's a bad fat. In fact, it is the best fat ever produced on this planet. So, and now it will come from US and we'll start accepting it. The problem is we are not aware of our own wealth. Ayurveda might be having lot and lot of solutions that has been proven by the part yoga, meditation,
Correct.
pranayam. My prescription starts from Yog Nidra Pranayam, and then the sequence of exercises Baba Ramdev ji के वो 12 step के exercises they have become viral, वो मेरे OPD में भी एकदम viral है. So these are the things. There are a lot of things. Allopathy has nothing to offer for polycystic ovarian syndrome. But the saddest part is we don't know what is there in Ayurveda.
That is true. That
So
is
there
true.
should be multi-pathy approach, multidisciplinary we are talking. Multi-pathies, they should come together and we should start. A friend of mine, he was advising something, but that therapy was too expensive and he lives somewhere in Ahmedabad. So that was a local kind of therapy he was offering in Ayurveda. He's got publication also, but there were 3 or 4 cases, and such an expensive thing which doesn't have a clear-cut benefit and side effect and everything identified. I will tell you the saddest story. The first IVF baby, when it was born in UK, 2 months later in October, our Durga was born. And with better method,
Correct.
Dr. Subhash Mukherjee has employed those methods which we are using today. And that Louis Brown was born by natural egg collection. But the late Dr. Subhash Mukherjee did not collect those things as evidence. And he had to commit suicide because neither government nor international academicians, they believed him.
That is true.
That is our biggest irony.
Yeah. That is true. Thank you. Thank you so much, ma'am. And I would like to just close this session, wonderful one, by speaking a little bit about the book that you have and encouraging people to read about it. So if you could tell us how to...
A to Z of PCOS, everything you wanted to know, and that is story based. And every symptom, every treatment, everything is written A, B, C, D, E, F, G. We have taken adolescent PCOS, metformin, M में metformin in PCOS, diet, D में diet in PCOS, and we try to just एक situation लेके, and those are almost true stories we come across. I am a completely PCOS clinic. 95% my patients are only PCOS. So those kind of stories we are sharing, you can understand it easily. उस वक्त हिंदी में नहीं लिख पाए थे, अभी उसको हिंदी में करना है, और डॉक्टर रत्ना ने भी प्रॉमिस किया है. So we'll talk to Vimy and we'll come across, we'll sit across once I come back from US, and we'll come with Hindi version very soon.
Thank you, ma'am. Thank you so much. And thank you, Priyal, for the wonderful session that you had.
All the channels, all the platforms, wherever you buy books, Kindle, Amazon, and everywhere.
Thank you. Thank you. And we will definitely work together for more vernacular versions. So thank you so much. Thank you all the audience for joining us today, and have a great evening, everyone. Thank you.
Thank you so much, everyone, for joining.
Bye, Priyal.
Bye.
Bye bye.
Bye bye.
Bye bye, Dr. Ratna. Bye bye.
Bye bye.